Okay, ma'am.
So, ma'am, shall we start?
Yeah. Whenever you say.
So, ma'am, it's 3, 2, 1. Over to you, ma'am.
Yeah. Thank you so much. We would like to welcome you to this journal club and research methodology workshop for the month of July. And we have got the theme for this month is going to be urogynecology, and it is an honor to invite you. And we would like to welcome Dr. Sheila Mane, Madam, the Vice Chairperson of ICOG. Dr. Parul Kotadawala, the Chairperson of ICOG, will be joining later on. Dr. Sarita is joining from US. And I would like to welcome all the experts, Dr. Dheera, Dr. Srikala Prasad, Dr. JB Sharma, and Dr. Archana Kumari. And this I'm doing on behalf of myself and Dr. Radhika, the convener for the programs, and the coordinator for today, Dr. Nisha from AIMS. The first, there will be a talk by Dr. Radhika that is going to be on basic statistics for obstetrician and gynecologists. And there will be presentation of 2 journal articles. And one will be the joint position statement on the management of mesh-related complications for the FPMR specialist. And that is from a recent article in 2020 presented by Dr. Gauri Bawa, and the experts will be Dr. Dheera, Dr. Srikala Prasad, Dr. JB Sharma, and Dr. Archana Kumari. The second article will be the complications following retropubic versus transobturator mid-urethral synthetic sling replacement. And that is a very recent article from the International Journal of Urogynecology 2023, and that will be presented by Dr. Nisha. And Dr. Radhika is the National Coordinator for Clinical Research from 2017 to 22. And she's a national corresponding editor for the Journal of Obstetrics and Gynecology, 21 to 24. She's got several awards, and the main award she's got is the recipient of the ICOG Visiting Professor Award of 2019, the FOGSI Korean Award, and she's a WHO Fellow on Advanced Course on Monitoring and Evaluation, Innovations in a Dynamic Health System Environment. A very rare combination, Radhika. Radhika is both a clinician as well as a wonderful researcher, and she's guided many of us in our committee work also. She's an expert reviewer for Cochrane collaboration, JOGI, IJMR, and JSFOG. And she's got almost 75 publications in international and national journals and has edited 3 books. A special interest and expertise on evidence-based healthcare guideline development. Welcome, Radhika. And I'm the Vice President for FOGSI for this year. I'll be the other convener. And Dr. Nisha will be joining a little later. We got the blessings of the President FOGSI, Dr. Jaideep Tank, Dr. Parul Kotadawala, and the Secretary General, Dr. Madhuri Patel. And it's my honor to welcome Dr. Sheila Mane, Madam, for her blessings. And she's the ICOG Vice Chairperson of 2024. She's currently a DNB faculty at KCG Hospital, Bengaluru. Was an ICOG Governing Council member, President of Isopop Society of Bengaluru, Bengaluru Menopause Society. Has conducted several academic programs for postgraduation.
Yeah, thank you. Thank you, Charmila.
Thank you so much, ma'am. We would request you to give your blessings before we start the program.
Yeah, good afternoon, everybody. And I'm very happy to see that this research methodology JOGI workshop we are doing in association with ICOG. And a very good theme, that is a urogynecology theme, which has been selected. And I know I'm very happy to see Dr. Radhika, and I think all of us, we know that all of us are really gearing up for this FOGSI as well as ICOG. And these type of academic activities related to research methodology, where we are trying to trying to see that more people develop interest in presenting papers and articles and contributing to the journals. So these type of program will definitely help not only the postgraduate, but also the consultants, because it generate interest. And I think through this media, that is webinar, we are able to reach out to so many people. So I would like to thank Dr. Radhika and Dr. Charmila for taking up this initiative. Also the today's presenters and all the chairpersons who are going to be there with us, like Dr. Archana, Dr. JB Sharma, and everyone here. So I welcome all of you, and once again, all the best. Yeah.
Thank you so much, ma'am. I would like to introduce all the experts because the coordinator will be joining a little late. Dr. Sarita is the Secretary of ICOG, and she'll be joining a little later. The first talk will be by Dr. Radhika, and the second will be the article presentation, and the experts are Dr. Dheera Samdaria from Manipal, and she's a consultant at Jaslok Hospital and Bhatia Hospital, Mumbai. has been a scientific coordinator in Conference Urvashi, which is an annual Urogynec conference of KMC Manipal in 2023. Has been a guest for faculty at Haldwani and Bathinda. Her publications have been on awareness and attitude towards aesthetic gynecology among Gen Next in India Direct. The second was on easy and educational, a sacrospinatus ligament fixation. It's an innovative technique for an age-old procedure. She's a member of several organizations, and the interest is to develop a dedicated team in urogynecology and pursue it as a specialty and be instrumental in improving women's health. The second expert is Dr. Srikala Prasad, who's a professor of urology at Government Kilpak Medical College, and she was the past president of the Chennai Society and the vice president of the Tamil Nadu chapter of FOGSI. Has got almost 32 years of experience in obstetrics and gynecology, and she's got a Best Paper Award for her work on pelvic floor disorders. Has contributed several chapters in several books. Has got multiple publications. Has organized several conferences. Has got lots of awards to her credit. And she's a regular faculty in state, national, and international conferences and live operative conferences. Welcome, Dr. Srikala and Dr. Dheera. And the third expert is Dr. J.B. Sharma, who was the chairperson of the Urogynecology Committee of FOGSI, and he has been awarded the V.C. Roy Award by the Honorable President of India in 2015 for his research in OB-GYN. It's got almost 350 publications in indexed and non-indexed journals, 200 being peer-reviewed indexed national and international journals. Has authored textbooks of obstetrics and midwifery and gynecological nursing, and he has won several awards. Has been the editor-in-chief of several books, several journals, and is one of the Indian Council of Medical Research Amrut Body Unicum Prize for his research work on anemia during pregnancy. Has won the Best Paper Award in 2003 on his role of lycopene in prevention of preeclampsia. Welcome, Dr. J.B. Sharma. And the fourth expert is Professor Dr. Archana Kumari, who's a secretary of Ranchi OG Society from 2023 to 25. She's been the East Zone coordinator for the quiz committee, been the founder secretary of the IFS Jharkhand chapter. He's been the vice president of ISOPAB, Ranchi OG Society, has been the convener of the clinical research committee, been the organizing secretary of several conferences in Ranchi and elsewhere, has got a teaching experience of 18 years for DNB, undergraduate and postgraduate examiner, as well as a PhD supervisor, has got almost 30 publications to her credit, 7 chapters and books, and she's done 5 funded research projects. And she's been awarded the MS Signature Award, the Dheera Award, the FOGSI Achievers Award, the FOGSI Appreciation Award, and the Best Free Paper Award in the East Zone UA FOGSI. And she's also going for elections this year, and we'd like to wish her the best. And the presenters for today, thank you, Archana. The presenters for today are Dr. Gauri Sanibawa and Dr. Nisha. Thank you so much. And we'd like Radhika to start her talk on the research topic.
Thank you very much, Charmila. That was indeed, very detailed introduction to the program, and also for introducing me so nicely. Good evening to all. I'm going to be just touching on few basic, as the title itself shows, basic aspects of biostatistics for the gynecologists. So now what we basically, this is going to be the outline of the talk today. So just the basics of clinical trials, the types of data, because it's important for us to understand the type of data before we actually start, analyzing the data or even critically appraising the literature. So these are two aspects that I wish to basically talk about, because we as gynecologists, we are busy people. So critical appraisal of literature and to quickly eyeballing the published literature to know the quality of what has been published is extremely important for us. So what is a bell-shaped curve, standard deviation, mean, mode, median, parametric, non-parametric test, risk and odd ratio, probability, confidence interval, and p-value. So these are some of the points that I'm going to touch upon in the next about 15 minutes. So I'm sure majority of us know of the epidemiological studies. They could be experimental or they could be non-experimental, which are also called the observational studies. And the experimental are the interventional studies, which could be randomized and non-randomized. So why are we revising all this again? Because the type of data which is produced by each of these study type varies. And therefore, the tests which are applied as inferential statistics or descriptive statistics are also different. And that is why we again and again need to revise on the type of studies that are there, especially when you are planning a study. It is extremely important for you to be able to describe and relate with the statistician as to what exactly that you are trying to do, whether it is an experimental or a non-experimental study, so that he is able to tell you exactly about what sample size and what kind of test that you would like to use. So these could be population based or individual based, which could be again descriptive or analytical. And when you come to individual analytical studies, it could be cross sectional, case control, and cohort. So these are the few bare basics of the epidemiological studies. So the basic topic for today, the focus of today's talk is the types of data. So what is a data? Data is, basically a study. It's a set of observations of variables which come out of a study, and the purpose of a study is to collect the data on a specific area of research. Very simple. So the variables could be demographic information of the patients with respect to an illness. It could be simply basic things like sex, age, height, etc. So we know the various kinds of data can be there. So this data could be of the qualitative type. This could be qualitative, which is also called as the categorical data, or it could be quantitative or numerical data. Now, when we say it is qualitative data, it is actually not in numbers. So, this could be two types, nominal and ordinal. So, when we say it is, what do we mean by saying a qualitative nominal data? Now, the examples are blood type. So, it could be A, O, or AB. So, there is no number that is attached to this. Similarly, ethnicity, it could be Asian, Caucasian. So, these are categorical qualitative data, or it could be ordinal. So, there is a certain hierarchy where it is in a certain order. So, for example, we have the VAS code for pain, or it could be a pictorial chart for bleeding. So these are various levels, according to the various degrees, these are categorized as mild, moderate, severe. Pain could be mild, moderate, severe, extremely painful, no pain at all. Same is could be the case with sleepiness. So the qualitative data could be nominal or ordinal. It is very important to remember this. Majority of us know the quantitative data because this is what we do in major types of most of our clinical research. Now, these quantitative data can be discrete. So, when we say discrete, it means a few numbers which are unrelated to each other. It could be heartbeats, it could be number of visits of a person in the OPD, or it could be the number of offsprings. So, these are discrete data, or these could be continuous data. The height, weight, hemoglobin. These are they increase from small numbers to big numbers. So, there is a because they go up to infinity. So that is why these are called as the continuous data. So again, to repeat it, qualitative and quantitative data. Qualitative is synonymous with categorical, and qualitative could be nominal or ordinal. So ordinal when there is a certain hierarchy, nominal is non-hierarchical, and quantitative is discrete and continuous. So the derived data from these could be in the form of percentages, ratios, rates, and scores. So without going into too much of that, now let us understand what is descriptive and inferential statistics. So descriptive is when we describe a data, right? So it is used to summarize the attributes of a sample in a way that a pattern can be drawn from the group, basically to understand what the description of the population gives us by way of a researcher. And it enables a researcher to present the data in a meaningful way for the interpretation. So the examples of these are mean, median, or it could be mode, or the standard deviation range. These are all descriptive statistics. Whereas inferential statistics is applying the statistical procedures on the results obtained from the samples to make an inference at the target population level. So these are the various types of tests which are applied for the hypothesis testing, and these could be the test for hypothesis testing, or it could be regression analysis when there are more than one variable involved. So again, the type of data and the type of statistics are two important things that are important for us to understand when we either screen the literature or start a research. So the distribution of the data could be normal or not normal. So when we say normal, it is when it follows a definite pattern, the sigmoid curve, it is called as normal, and all the others are not normal. Okay, so they could be trimodal, they could be bimodal, skewed, and there could be the ones with outliers. So this is important for us to understand, as you will find in the next few slides. So what is a normally distributed data? Normally distributed data is the one which, so there is one slide which has gone missing. So let me explain in this. So there is data which has got a sigmoid curve. Now in this, the x-axis shows the distribution of data and the y-axis shows the frequency of the data. As you find, you can see here, majority of the data is in the center because that is where the peak of this wave has come. So the distribution of data on both sides, it could be on the right or on the left side. This distribution is the variance or the distribution of the data across the mean, right? So majority of the data which is present between the plus and minus one standard deviation is about 70%, 68.4%, and plus and minus 2 standard deviation is to the tune of 95%, and plus and minus 3 standard deviation is to the tune of 99%. Again, it is very important for us to understand this, because when we plan a study, we need to know what is the kind of population that we wish to target, what is the number of people that we are wanting to study, and depending on the kind of data that we receive, it is important for us to be able to interpret the data. So in a normally distributed data, the sum of measurements, mean is the sum of measurements divided by the total numerical values of the number of values which have been used for the measurements. So this is the mean. Median is the middle value of all the data list. Mode is the most commonly occurring value. So here, if you see, this is an example, the age in a classroom. So if you take a sum of the
We're unable to hear, ma'am.
Hello. I think there is some network issue.
Yeah, madam. Madam, you are muted.
Okay, is this better? Yeah.
Yeah.
So each data, also important to remember, will have a range. For example, if you are studying the height, the height of the students in a classroom will have a certain range. And within that range, there is also a variation. So the number of students who measure between 5 to 5.1 could be the number of children who are sitting in class 6. In class 7, the height increases. So within a class, there is a range. And then when you take of the entire school, there is a variation. So it is important for us to identify the difference between the range and the variance. So all parameters have variations, but also have the range. Majority of the readings fall within this range. The example I just gave you, the height. So range is between the highest and the lowest values. For example, if you take the temperature, 19 to 25 degrees, the range is 6 degrees. And however, we also know the outliers could be there. So, without going into too many complications, this is a very simple example of a standard deviation. Standard deviation is also a type of variation. I told you the sigmoid curve, plus and minus 1 standard deviation. Here is the measurement of cholesterol. Now, we find that about 70% of the people have the cholesterol which varies into plus or minus 25 milligram percent, that is plus and minus 1 standard deviation. About 95.4 people lie between the plus and minus 2 standard deviation, and there the variation of cholesterol is 50 milligram percent. 50 on the two sides, right? 225 was the plus 1 standard deviation, and 250 is plus 2. And plus and minus 3 standard deviation, 99.7, have a variation of 100 on either side. So it is very important to know this, because your inferential statistics depends on the distribution of data, right? and also the interpretation of the data. So how can you use the standard deviation intelligently? Now, if you read a study which says that the duration of hospital stay following a surgical procedure was 8 plus or minus 1 minus 3 days. So, plus or minus 1 standard deviation, meaning 70% of the patients stayed in the hospital between 5 to 11 days. Whereas if you see 99.7%, so here it is minus 1 to 17 days. So, this is not possible. You can't be having minus 1 day following the surgery. So, there is some problem in this presentation of data. So, it is important for us to know what is standard deviation. So, obviously, this probably was not a normally distributed data, and inferential statistics has not been applied properly. So, you could use the standard deviation intelligently. So, to summarize, so prior identification of the data, nature of the data is important. To understand whether it is normally distributed, there are tests. This is the Smirnov test, which can be used to identify whether it is normally distributed. We just now understood that the mean, standard deviation, range values in a normally distributed data are almost the mean, median, and mode are the same, and SD and range values have to be identified. Skewed data is more often interpreted in mode and interquartile range, and it is important to categorize the data. In the categorical data are expressed in ratios and percentages, and it is important to indicate that in parentheses. So the tests, the inferential statistics now varies. I've been saying repeatedly right from slide 1 that the inferential statistics changes as per the type of data. So you have the continuous variables and the categorical data, and these are the inferential statistics which are used. So for the parametric, it is t-test and ANOVA. Non-parametric, I'm sure majority of us are familiar with these tests: sign test, Kruskal-Wallis, Wilcoxon, rank sum, and the signed rank. So I'm not going into the details of these. I'm just here to familiarize because it's a very short talk. Sensitization, it's more like a sensitization program. So the categorical variables, it is important to note that they are never normally distributed. None of the categorical variables are normally distributed. They are always non-parametric. So here, the inferential statistics, depending on the type of data, meaning the nominal or ordinal, varies. So here it could be Fisher, the Fisher exact and the chi-square are similar to both. And McNemar's test, here it is empirically written, the two are a little different. And then there are non-parametric tests and the binomial probability test. So this is just to understand that the type of data is important to understand, and therefore the inferential statistics vary. A very brief line about multivariate analysis, which is very often used. This is in the presence of multiple variables affecting the event, and the role of each variable is analyzed, and it is important to understand what are the other constants which implicate the outcome of the event. So, to understand how important this factor is, that is why you have the multiple linear regression, multiple log regression, discriminatory functional analysis, and so on and so forth. So, it is just to say that when you have multiple variables which affect the outcome, now, this is to be very importantly differentiated from confounders. So, I'm not going into those. It is actually very interesting to understand. When you plan a study, you must understand what are the confounders, and that is where you start matching the population. You need to have the same confounders in both. And that is why when you have an observational study, you are not able to factor for the confounders, so the risk of bias is more. So, when you have multiple variables which are affecting the event, then the role of each variable is analyzed using the multivariate analysis. So, I would encourage everybody to just go through these because it is important. Very briefly about confidence intervals and p-value that we keep reading on all the publications. I just want to say the bottom line is always read the confidence interval along with the p-value. The p-value is a test of significance, and we say that p-value less than 0.05 is significant. Now, why do I say confidence interval on its own adds great value to the p-value? Why is it that? This slide shows this. What is the confidence interval? If a study were to be repeated many times over, the confidence interval will include the true value in 95% of the interpretations. So you repeat it 100 times, 95% of times the results would be there in the confidence interval, and that is expressed as a confidence interval, and it indicates the highest and the lowest events in the trial, and the limits are within the 95%, that is the plus and minus 2 standard deviation of the Gaussian curve. We just talked about the curve here. So when we say the confidence interval, it lies between the plus and minus 2 standard deviation, meaning 95% of the results lie within the confidence interval. It is precise or when it is tight, meaning when there is a low variation or the spread is small or in a large sample size. That is why traditionally we always talk about a large sample size for a good clinical outcome for a well-powered study to have derivatory results, right? So generally when the confidence interval is less than 0.85, when the range is within less than 0.85, meaning for example 0.56 to 0.73 is significant. When it is 0.57 or it crosses the one value, it is generally not considered very significant, right? So the p-value is basically it's a probability whether the observed value is by real or is it by chance. Generally accepted when it is significant when it is less than 0.05. So the value of 0.05 indicates that the probability of observed value is obtained is less than less than 5% that it has come by chance, right? So when a study says the p-value is less than 0.05, and you also look at the confidence interval, even though it has not the probability of the result being less than 0.5, meaning 5 out of 100, the chance is it is less out of chance out of how do I say that? So I'll just read this again. The result indicates that the probability of observed value obtained by chance is less than 5%, right? So when the p-value is less than 0.05 and you read the confidence interval is crossing 1, it means even though the results are not erroneous, but the clinical implication, because it is crossing 1, the confidence interval is crossing 1, the results are not very significant, even though the results are not by chance. That is what I'm trying to convey, right? So anything which is less than 0.05 with a good confidence interval is of clinical importance. Anything which is more than 0.05, and it is up to you. A priori, when you start your studies, it as a researcher, you can fix your p-value, what you think is important for your study, depending on the prevalence and the sample size, right? So clinically important effect, 40% difference in treatment success may not be found to be statistically significant. Why do I say this? It is because even if the p-value is significant, you still need to see as a clinician whether it is clinically significant. I might say that the effect of a drug for increasing the hemoglobin by 1 gram percent is not clinically it doesn't have a good p-value. The p-value is more than 0.05. However, as a clinician, I might take it as an important result that within 2 weeks' time, if the hemoglobin increases by 1 gram percent, it is significant. So whatever be the p-value, there are two factors that determine the interpretation of the results. One, your clinical judgment. Second is the confidence interval. That's all this slide says. Right? Then I'm sure majority of us already are aware of the risk and the odds ratio. Risk ratio is used for the cohort studies. The case control are the odds. The odds ratios are used for the case control studies. So I just wanted to keep this slide here because as clinicians, we should be able to explain to the patient and also interpret the results of a publication. So what is the number needed to treat? It is very easy for us to tell the patient that if there are hundreds like you, one patient benefits. That is something that patients understand very well. How do we get the number needed to treat, the value? This is the absolute, so the ARC is the absolute risk, the number of events that happen in the control group. ART is the number of events in the treatment group. The number of events which happen in the control minus those in the treatment group is the absolute risk reduction. The number needed to treat is a simple formula of 100 by the absolute risk reduction in percentage. Generally, number needed to treat 50 to 100 is considered significant or acceptable. So the example is, now let us take a drug which reduces the maternal mortality due to postpartum hemorrhage. 5 out of 1000 died with standard care. 4 out of 1000 died because of XYZ. Absolute risk reduction is 0.5 minus 0.4. So it is ARR is 0.1. So number needed to treat is 100 by 0.1. So number needed to treat is 1000 patients to save one patient. So that is not a good drug because we decided that number that needed to treat is generally 50 to 100. Right? So it's a very simple formula. Again, I would encourage everybody to go through this. So my final take home points is it is important to understand the type of data that you're working with. Continuous data is generally identify whether it is normally distributed. Categorical data are usually non-parametric. Rule of thumb is if the number of observations is more than 30, generally the standard deviation is less than 25% of the mean and it can be taken. So this is in case you are not able to apply the test that I was saying, the Smirnov test. One can just eyeball and look at the distribution of the data. If the standard deviation is less than 25% of the number of data more than 30, then we can take it to be normally distributed. Appropriate descriptive and inferential statistics are then applied. And the CI, the confidence interval and p-value, along with the clinical implications, have to be taken together. And over and above everything, it is the clinical implications that take precedence. So with that, I thank you very much for a patient hearing. I think that's been an overload of statistics there, but I thought I must just present a few points which are important as a clinician and for us to be, just to be familiar. It is more like just a sensitization. So thank you very much. So any comments, please, Dr. Archana?
Yes, madam, that was an excellent talk about the basic of biostatistics. It was a thorough revision for me also. And I think it must be of great benefit to all the postgraduates and residents who are logged in. And to understand the type of data, the descriptive statistics, at least is so very important. Also the inferential statistics, what type of test they are going to apply. That also you described in a very simple manner. And I think you also elaborated and on that confidence interval is more important than p-value. PG is often, they will say my result is significant. It is less than 0.05, 0.005. But of course, that has to be correlated with the confidence interval also. And I think that is all from me.
Thank you. Thank you so very much. Dr. Shrikala, please.
Good evening, madam.
Good evening.
Great.
Nice to meet you.
Thank you. Wish you the same. JB Sharma sir also I can see. Good evening.
Hi Radhika,
hi,
you
how
are
are you?
wonderful as usual. Hai Radhika. Hi Shrikala ma'am, how are you?
Hi sir. Namaste. Namaste to all of you.
राधिका से तो मुझे एक अलग से क्लास लगवानी पड़ेगी.
Lots and lots of information.
Thank you very much. Dr. Parul, I can see. Warm welcome to you, Dr. Parul.
Thank you.
Good evening, sir.
Very
Good
happy.
evening.
Good evening, Shrikala ma'am.
Oh, hello.
Good evening. Good evening.
Good evening.
So I think with that said, can we go to the next session, please?
Yes.
Yeah. So I think Nisha has yet to join. Dr. Sharma, वो निशा आई नहीं अभी तक है ना?
Yes, ma'am, join, ma'am.
She has joined.
हाँ,
She is sitting with me.
so please
She is
take
sitting with
over.
me. She is my
Nisha,
office
take over.
only.
Yeah. Please take over.
उल्टा हमारा पहले करवा दो.
So, good evening, everyone. Moving to the next session. So, in session 2, we are going to have
There is
two
echo.
article
There is-
presentation.
Are you logged in from two sources? We are able to hear some echo.
या तो मेरी इधर से आ जाता है ना. Can we do together like or?
Yes, sir.
कौन? एक ही कर रही है, कर रही है. मेरे को वॉइस आ रहा है.
Yes, this is fine.
So Nisha and we are in the same room. If we are using two computers, then voice is coming. So I think we use one computer.
Yes, yes, yes.
Good evening, everyone. Now we are moving to the next session, that is the paper article presentation. And our first speaker is Dr. Gauri.
Hello, good evening.
Yeah, good evening, Gauri. Please carry on.
Yes, ma'am. Good evening, respected sir and madam. I'm Dr. Gauri Bawa, secondary DNB resident from Sir H.N. Reliance Hospital, Mumbai. I'm presenting a journal on joint position statement on the management of mesh-related complications for the FPMRA specialist. So what is a pelvic organ prolapse? Pelvic organ prolapse is the herniation of the pelvic organs to or beyond the vaginal walls. That is the anterior compartment, posterior compartment, apical compartment prolapse. A higher prevalence of symptomatic pelvic organ prolapse is suggested by the number of women undergoing the surgical prolapse repair. Around 2 lakh surgical procedures performed annually in the US for prolapse. Hysterectomy, particularly when performed for the indication of pelvic organ prolapse, increases the risk of subsequent pelvic organ prolapse. In recent studies, frustration with surgical failures has prompted the development of materials and techniques using the synthetic mesh. This led to the development of transvaginal mesh. What is pelvic apical vaginal prolapse? Defined as the descent of vaginal cup scar or cervix below a point which is 2 cm less than the total vaginal length. Loss of apical support is usually present in women with prolapse that extends beyond the hymen. There is growing recognition that adequate support for the vaginal apex is an essential component of a durable surgical repair for women with advanced prolapse. Because of the significant contribution of the apex to the anterior vaginal support, the best surgical correction of the anterior and posterior walls may fail unless the apex is adequately supported. Hence, vault suspension procedure, sacrocolpopexy, and sacrospinous ligament fixation is an important procedure in prevention of vault prolapse in concomitant hysterectomy surgery and treatment of vault prolapse. What is stress urinary incontinence? It is an involuntary loss of urine on effort, physical exertion, or with an increase in the intra-abdominal pressure upon sneezing or coughing. International Continence Society defines it as the complaint of any involuntary loss of urine on effort or physical exertion, such as sporting activities or sneezing or coughing. According to the American Urogynec Society, SUI is loss of urine that occurs at the same time as physical exertion. The conservative management includes weight loss, pelvic floor physiotherapy, incontinence specially, surgical procedures like birch colposuspension, biological bladder neck slings, and urethral bulking agents. The surgical procedures are more invasive and are associated with increased morbidity. This has led to the development of mid-urethral sling for the treatment of SUI. So because of the complications associated with synthetic mesh, from medical marvel, it has become a medical menace. In some circumstances, this technique seems to confer durability, but the implants themselves introduce unique risks. The complications seen with the use of mesh were bleeding, mesh erosion, exposure, dyspareunia, chronic pain. These complications were seen more with the transvaginal mesh, which led to its ban worldwide. The 2011 update to the Food and Drug Administration's public health notification regarding use of transvaginal mesh stated that these complications are not rare and cannot be and can be difficult to treat. The scientific approach to categorizing mesh complications and optimal methods to address them have been complicated by the rapid proliferation and evolution of materials and techniques that have been used over the past 20 years in the surgical treatment of pelvic floor disorders. We should strive to optimize the treatment at the initial diagnosis of a mesh-related complication. This document is a companion to the committee opinion released jointly by the American College of Obstetrician and Gynecologist and the American Urogynec Society, which was a reference for the OBS-GYN specialist. It has been developed by AUGS and the International Urogynec Association as a resource for the subspecialist in female pelvic medicine and reconstructive surgery. The goals for this joint position statement are using the best and most relevant evidence available, provide guidance for the FPMRS subspecialist caring for the patients who may be experiencing mesh complications, to provide an algorithm outlining the treatment choices for patients with mesh-related complications that can be used as a platform for shared decision-making in the treatment of this complication, to identify and prioritize the gaps in evidence concerning specific mesh complications and their treatment, to identify the provider and health facility characteristics that may optimize the outcomes of treatment for these complications. The limitations are this document does not explore the risk factors for mesh complications, the patient selection, instructions, and surgical techniques that may reduce the likelihood of such complications are beyond its scope. Similarly, for the purpose of this document, voiding dysfunction after the synthetic mid-urethral slings, recurrence of stress urinary incontinence, or the prolapse after mesh-based repair are not considered true mesh complications. They reflect functional outcomes. Finally, issues related to sexual functions after mesh-based surgeries are extremely complex. This document addresses post-operative sexual dysfunction only as it is related to mesh-related pain for the woman or for the partner. Surgical procedures for the treatment of mesh complications are as follows. Mesh revision. It includes either no mesh is removed or a small edge of mesh is removed such that the structural integrity of the implant is left intact. Partial vaginal mesh excision. A segment or component of the mesh is removed or transected such that the structural integrity of the implant is altered. Complete vaginal mesh excision. The entirety of the mesh that is in contact with the vagina is excised. Extravaginal mesh excision. This involves removal of the segments or components of the mesh beyond or not in contact with the vagina. Total mesh excision involves a removal of 100% of the implant. The methodology was to define the treatment of algorithm. The writing group adhered to the iterative Delphi type process that started with the premise that the approach to treatment of mesh complications should begin with stratification by device type, mid-urethral slings, transvaginal mesh, and sacrocolpopexy. Then specific conditions were identified as starting points for the key decision. And after each round of algorithm development and discussion, the decision nodes were investigated using PubMed literature search for relevant diagnosis and treatment terms. And the available evidence was used to determine the level of support for each decision node. When necessary, the algorithm was modified to reflect the relevant evidence. Each subsequent iteration of the algorithm involved new literature review that was tailored to address questions and support for the issues that arose with each iteration. The algorithms were further developed and refined based on this literature review, and the process was repeated until the consensus was reached. The level of evidence supporting each node and the grade of corresponding recommendations were defined using an adaptation from Canadian Task Force on Preventive Healthcare for specific clinical preventive action. The grades of recommendations are as follows. Grade A, there is good evidence supporting the recommended action. Grade B, fair evidence supporting the action. Grade C, there is conflicting evidence that limits the recommendations. Grade D, there is fair evidence recommending against the action. Grade E, good evidence recommending against the action. And grade I, there is insufficient evidence to make any kind of recommendation. It is critical to provide it is critical for a provider offering surgical treatment of mesh complications to understand that many patients will require multiple procedures for their complications. For example, repetitive mesh revision procedures will complicate or even render impossible the complete excision of mesh. Therefore, if a given treatment is unsuccessful, consideration should be given to next advancing item on the algorithm to minimize the likelihood of the multiple surgical events without clinical progress. Special notes about using the treatment algorithms are the algorithms in this position statement are not intended to use in the perioperative period, like immediate post-op pain, neurologic complaints or findings or other functional issue may require an immediate diagnosis and treatment that is not relevant to the literature search performed. These algorithms are only applicable to the patients with type 1 polypropylene mesh implants. In instance, when a patient has both mesh exposure and pain management should be determined on the basis of pain. The coexistence of mesh exposure in the presence of pain seems to have a little impact on the effectiveness of surgical treatment of pain. The algorithm for mid-urethral sling mesh exposure. If it is bothersome to the patient, we might choose to observe. If the patient wants to be treated or it is bothersome, like a patient is having discharge, bleeding or any partner pain, and if the mesh exposed mesh is only less than 1 centimeter, we can go for office streaming. If it recurs, we can go for mesh revision. If on recurrence, we can go for partial or complete vaginal exposure. If it is included that there is visceral perforation, bowel or bladder, then endoscopic partial excision should be opted for complete excision of mesh. If during algorithm for mid-urethral sling with pain or dyspareunia, if there is focal vaginal pain at the sling, we can go for physiotherapy or surgical treatment. In surgical treatment, if there is a mild SUI, we can go for partial vaginal excision, and if the pain persists, we can go for complete vaginal excision. For extra vaginal pain, we can opt for physiotherapy. If there is obturator mid-urethral sling, we can go for partial vaginal excision. And for retropubic mid-urethral sling, we can go for extra vaginal mesh excision with or without vaginal mesh excision. This diagram shows retropubic mid-urethral sling with complete vaginal mesh excision. The shaded area is excised. This figure 2 shows example with retropubic mid-urethral sling, partial vaginal mesh excision. Figure 3 shows complete vaginal mesh excision. Figure 4, it shows extra vaginal mesh excision, left groin sling arm, the area shaded in red is excised. Figure 6, it shows transobturator mid-urethral sling with total mesh excision. This is the algorithm for sacrocolpopexy with mesh exposure. It is similar to the mid-urethral sling. If it is not bothersome to the patient, we can go for observation. If it is bothersome or the patient wants to be treated surgically, then we can opt for vaginal trimming with or without estrogen treatment. Or we can go for surgical revision, partial excision with or without epithelial closure or partial colpoclasis. If it recurs, then we can go for complete surgical removal. This is sacrocolpopexy with pain or dyspareunia. If the patient has elicited pain from focal area or obgraph, we can go for physiotherapy or surgical revision and partial excision with or without epithelial closure or partial colpoclasis. Or if it fails, we can go for complete surgical removal. If there is infection with exposed mesh, then we can go for complete surgical removal. If the mesh is not exposed, then we can opt for antibiotics with radiological drainage. If it is associated with back pain, in 85% cases of osteomyelitis. They present with back pain. So we can go for imaging and lab diagnosis for osteomyelitis, and we can go for surgical treatment if antibiotics and medical management fails. For transvaginal mesh exposure, if it is not bothersome, we can observe with or without estrogen management. If it is bothersome or the patient wants to be treated, if the exposed area is less than 1 centimeter, we can go for office streaming with estrogen. If it fails, we can go for surgical revision of mesh. If it also fails, we can opt for partial excision followed by complete excision if it also fails. For transvaginal mesh, with or without with pain or dyspareunia. If it is focal pain, we can go for physiotherapy or surgical treatment. If surgical treatment, we can opt for partial vaginal mesh excision. If it fails, we can go for complete vaginal mesh excision. If it is non-focal pain, that also we can go for physiotherapy and surgical management, considering complete vaginal mesh excision with no residual mesh left behind. If a patient has diffuse pain or felt revision, then we have to opt for complete vaginal mesh excision. If there is extra vaginal pain, nerve entrapment or infection, we can go for multidisciplinary approach and decide for extravaginal or total mesh excision. This is the example of transvaginal mesh, where the partial vaginal mesh excision and extravaginal mesh excision is done. The area shaded in red is excised. This is also transvaginal mesh, where extravaginal mesh excision, both right groin, arms are excised. This is PVM mesh revision, where area shaded in red is excised. The identification and prioritization of gaps. Mesh complications, particularly those requiring surgical revision, are inherently highly individualized and sufficiently uncommon that randomized clinical trials trials aimed at identifying best practices are unlikely to be conducted in near term. Given the dearth of experimental evidence, the grade of recommendation for our proposed algorithms varies between B and I. Therefore, this does not eliminate the need for high quality data to drive informed decision making. It is therefore critical to shift our focus to a registry based approach to evidence generation. If we can drive consistency in our terminology, both for presenting condition and for its treatment, and encourage data capture from most or all mesh complication cases, we will be better positioned to identify the best treatment options. At present, only the transvaginal mesh are banned, while using the mid-urethral sling and sacrocolpopexy continue to remain the standard of care. We now understand that the mesh characteristics such as filament type, density, porosity, and surface area significantly impact the behavior of the mesh in vivo. Hence, we should be cautious about generalizing mesh complication management data that are based on the patients whose implants contain materials that are no longer used. Following the specific gaps in the evidence were identified. Success rates of partial mesh excision of exposed sacrocolpopexy mesh with lightweight monofilament mesh devices. Safety of observation of asymptomatic mesh exposures in sacrocolpopexy. Risk of prolapse recurrence following different types of mesh excision. Effect of surgical techniques on outcomes. Specifics of surgical intervention for sacrocolpopexy related pain. Methods to determine whether to pursue partial or complete vaginal mesh excision in cases of transvaginal mesh related pain, and circumstances under which resection of the intrapelvic mesh arms is advisable. Strategies to minimize post-mesh resection prolapse. Conclusion. Consistent terminology for the diagnosis and description of mesh complications as well as procedures to treat them. Improved ability to delineate and publicize centers with superior experience and services for mesh complications. The availability of treatment algorithms are based on the specific complications that can assist in shared decision making. a shift in research resources to focus on the most important gaps in literature concerning treatment of mesh complications, availability of comprehensive high-quality registry data that inform and optimizing treatment of mesh complications in real time. Finally, it is our responsibility to provide evidence derived from scientific experience to fill the void that is in some cases allowing other forces to alarm or mislead patients. Thank you.
Thank you. You have done a good job. But for, am I audible?
Yes, ma'am.
Yeah, yeah, we can hear you.
Yeah. But for the clinician, we need to know certain things. Once a patient comes with a mesh complication, we need to really take a good history. What is her problem? Is it pain, infection, and all those details is very important. And what is the time interval between the index procedure and her onset of her symptoms? So first, history taking is extremely important. What are her areas of concern? Then a good clinical examination to see where the exposure is, what type of pain is. Are you able to mimic the pain? Supposing she says pain and on your pelvic examination you don't see any pain, then you will have to take it with a pinch of salt. A detailed examination, sometimes because of the severe pain, normally we do an office examination, but if the pain is very severe, you can do it under anesthesia also. Then you reasonably come to a diagnosis to what is her problem, and then you can take subsequent accessory investigations, which can include cystoscopy, imaging, ultrasound, as well as MRI, even a digital rectal examination, all those things, and mentally have in your mind what case you are dealing, so that a multidisciplinary approach will be very needed, because you cannot halfway through the theater call anybody else. So you must have in your mind what you're dealing, and then go forward. That is one thing. Second, we need to counsel them that this mesh removal, you told very correctly that less than 1 centimeter you can wait, and then all those things. So partial excision is what we normally do. And if it is a recurrent one and there is severe pain, you will definitely need a complete removal. But counseling plays a very important role. All these algorithms are helpful for us to guide us to do the clinical management. Counseling is extremely essential, that we have to tell them that, you may not be able to remove the mesh properly. And if you remove the mesh partially, for example, stress incontinence can recur in about 25%. If you do partial, if you do total more than 50%, it can recur. Similarly, the prolapse. So you must tell what is the incidence of recurrence. That is what our patient is bothered. So all these items are very, very important. And the need for repetitive procedures also must be told to them. And for some, even after you have done a good job, the fact that they may not be pain-free also, you have to tell. So I think if you follow all what has been given, we will be able to help our patients.
Yes, ma'am.
Dheera,
I think there were very useful comments. Thank you very much, madam. Yeah, Dr. Dheera, please.
Yes, ma'am. That was actually, as ma'am has already very concisely and she's given a very comprehensive summary of how to go about and see a patient and diagnose them and even treat them. I think I would just re-emphasize as what ma'am said of counseling of the patient, that a repeat procedure may be required or the next procedure may be required, and also counsel that there is, once we do the procedure, there can be a recurrence of their primary condition. Otherwise, ma'am has, yes, very comprehensively described it all. Thank you, ma'am.
Yeah, thank you. Dr. Archana?
Yes, because lots of urogynec experts are here. They have already given the comment. And of course, the comprehensive approach to the patient always starts with good history taking and examination, identifying the exact complications and then treating. And of course, the guidelines are there to just help us, the clinicians, but clinical acumen is very, very important. Thank you, Shrikala.
JB sir? JB sir, you would like to add something? You're unmute. Sir, you need to unmute, sir.
Yeah, excellent presentation by Dr. Gauri and by American Urogynec Society as well as IUGA. So it's a brilliant, and Dr. Srikala Prasad has already highlighted everything in this presentation. But we are seeing actually lot complications. I have got about 10 patients in my waiting list, man, in which my colleague have done laparoscopic abdominal sacropexy for them. And now they have got mesh erosion. So we have already operated 5 of those patients, and in one patient, the mesh was going into 3 loops of the bowel. So we had to call the GI surgeon. There were 3 holes at different parts of the small bowel. 1.5 feet of the bowel had to be resected. A 5-6 hour job. Another patient we could actually remove just whatever mesh we could get hold of. That patient got better. Third patient we did it, but then she was still having some persistent discharge, unhealthy. And then we again tried to reboot it, but this time there was injury in the bowel at the higher up, so we had to do colostomy for her. So a lot of patients, especially of sacropexy, we are getting. I still feel that this mid-urethral sling and transobturator sling for SUI, in them we are not seeing that many. Like we have done 180 odd cases, I think, of TVT, TOT. No, 2 or 3 cases only. I had partial mesh erosion, and all I did was just removal of that, what she said, only exposed part. And in one case it came back again, so we removed just that part, and the patient remained continent and she's okay. But this, sacropexy one, I'm getting a lot of problem with that. So, but we need to actually, I think we can make a registry as has been advised, because unlikely that any RCT will be done on them. So maybe Dr. Srikala and ourselves, we can, madam, start it a registry maybe in India. So all patients coming with complications and all, we can get them and all cases being done. And because I don't want that this TOT or TVT should go out of it is banned by government and all, because they're good techniques. But definitely, I feel that sacropexy, either it was laparoscopy, maybe they didn't do the peritoneal closure properly on them. But after that, I have stopped doing, even open abdominal sacropexy. I'm doing more of SSN fixations for these patients now. Wall prolapse, and we are getting reasonably good results. Majority of the patients.
Very good results. Very good results.
Yeah.
Only thing, especially like when you do a wall prolapse, you must take care to see if there is an enterocoel. Clearly put in your finger and see where the rectum is, check where the bladder is. Is there an enterocoel? If there is an enterocoel, you have to open and reduce and do a high ligation. So meticulous care while you operate will go a long way.
Sure. Thank you. Thank you. So maybe we can start the second one, if everyone allows.
Yes, sir.
I think these are very important points that have been put forth, and Dr. JP, I will totally agree with you. Having a registry would help us to go a long way, because it's important for now various conditions, especially in our country, to have some sort of evidence as to what is happening. So
absolutely. So we'll take, I think, advice from Dr. Radhika how to exactly start about the registry, and should we do only on complications, or should we do should we do only on complications, or should we do all patients where we are doing slings or this thing, maybe that of all the patients. So I think we can have a small group meeting. Dr. Srikala, you and myself, and this Dr. Samudra is also sitting there, and we have got other urogynec persons. So that will be a good idea, because we have got a closed community. I think we can easily keep the record, at least of all the urogynec people who are doing these procedures more.
Exactly. It's very much the need of time.
It's not, if you want to do like FOGSI people 25,000, that will never be possible. But a small group like urogynec and all, so we can definitely. So maybe Dr. Srikala, you can take a lead in this, and we'll be very happy to provide.
Sure, sir. Will do, sir.
Thank you.
Thank you.
So maybe we can ask
We
Dr.
can go to the next presentation, I think.
Yes, sir.
I got a nice cup of coffee. You are welcome to join. I miss
There is an echo. Dr. JP, there is an echo.
That's the beauty of physical meeting, no? Dr. Nisha, are you ready?
Yes.
Yeah, please start. Yeah. Can you make it slideshow, please? Yeah. Okay, so.
ये कैसे काटना? इसको काट.
यहाँ से करते, or you can do from my side also.
इसको minimize. Good evening, everyone. Myself, Dr. Nisha, fellow Urogyne in the Department of Obs and Gynae, AIMS, New Delhi, and I am going to present this paper published in International Urogyne Journal in May 23. That is complication following retropubic versus transobturator mid-urethral synthetic sling placement. So, as we all know, SUI is defined as any complaint of involuntary leakage of urine, and the prevalence is very low in young women, but it peaks around menopause, and 15.7% of the adult women suffer from this problem. So, the management is mostly non-surgical. Surgical is the most common management, and which includes colpo suspension, sling procedure, needle suspension, anterior colporrhaphy, and periurethral injection. Today, we are mostly confined to sling procedure, and we'll be discussing about retropubic TVT, tension-free vaginal tape, and transobturator tape. So the aim of the study was to compare composite complication rate between retropubic versus transobturator tape procedure. And it was a retrospective cohort study, and total 53,362 patients were enrolled in this, in which 36,991 underwent retropubic surgeries, and 16,371 were included in transobturator group. So all patients who underwent a sling procedure with codes for either sling transvaginal or tape transobturator were extracted from the database. And the patients undergoing oncologic surgery, concomitant non-gynecological surgery, and those with a pre-existing diagnosis of overactive bladder were excluded from the study. The primary outcome was to evaluate difference in the composite rate of adverse events beyond groups up to 12 months following the index procedure. And the secondary outcome was to evaluate differences in and risk factors associated with sling lysis for pain, retention, or mesh erosion between transobturator and retropubic group. So the results were higher proportion of retropubic surgeries were performed at teaching hospital to transobturator group, but surgeon volume was higher for the transobturator group. Surgeon volume was the number of surgeries done by a particular surgeon over the time period, the study time period, and it was more for the transobturator group, indicating that it needs less expertise. Now, this is the table showing the surgeries more commonly performed with retropubic and transobturator group. So in retropubic group, surgery was done in commonly with laparoscopic procedures, posterior repair, laparoscopic sacrocolpopexy, and robotic assisted surgeries. And transobturator surgeries were more commonly done with vaginal hysterectomy, anterior repair, sacrospinous ligament fixation, and obliterative procedures. The perioperative and post-operative complication, in retropubic group, the complication more common seen were urinary retention, sling lysis, hematoma, and bladder perforation. Whereas in transobturator group, the blood transfusion, surgical site infection, urinary tract infection, and these are seen more commonly. Moreover, second sling up to 1 year and post-operative pain was also more commonly seen in transobturator group. This table is the after excluding the common and risk factors. So it compares the post-operative complication after retropubic compared to transobturator, and it has been seen that in retropubic, sling lysis or excision or urinary retention and hematoma formation was more common, whereas urinary tract infection and repeat sling within 1 year was less common from transobturator group. and subgroup analysis of patients done undergoing sling lysis by sling type for certain indication, and it was seen that in retropubic group for urinary retention, sling lysis were more commonly performed than in transobturator group, whereas for mesh exposure and post-operative pain, there was no significant difference seen in between the groups. So why we are discussing about anti-incontinence and how it works as a surgery for incontinence. So continence is a interplay of anatomic and physiologic properties of lower urinary tract with control intact central and peripheral nervous system. And pelvic floor role is to just provide support to bladder and urethra and to facilitate normal abdominal pressure transmission to proximal urethra, thereby maintaining continence. And SUI, it occurs by two mechanisms, either by hypermobile urethra but otherwise healthy, or due to deficiency of urethral sphincter mechanism. So anti-incontinence surgery addresses the failure of normal anatomic support of bladder, neck, and proximal urethra. The surgeries available for SUI are abdominal retropubic suspension, in which Birch Kolper suspension is the gold standard, which can be performed either by abdominal or laparoscopic route. And other surgeries are mostly of historic background, and now we are more shifted to tension-free mid-urethral slings and pivovaginal slings. And today our discussion is based for tension-free vaginal tape and transobturator approach. So little bit about tension-free vaginal tape. It was first introduced in 1996, and in this procedure, a synthetic tape is passed transvaginally at the mid-urethral level through the retropubic space. And it was widely accepted because of it is minimally invasive and success rate is similar to Birch. But the complications are bladder injury, voiding dysfunction, detrusor overactivity, bleeding, infection, mesh erosion, and bowel injury. Now, the transobturator tape was introduced in 2001 as outside-in and inside-out procedure. In this, needle is passed through the vaginal incision and exits the obturator space without entering the retropubic space. So, in this, the patient positioning is very important, and which is thigh flexion, hyperflexion actually, 100 to 110 degree angle, which causes obturator nerve and its branches to move away from the trajectory of the tape. The two well-known TOT were Monarch and TVTO with similar comparable cure rate and satisfaction rate. And the complications are post-op groin and perineal pain, obturator hematoma, nerve injury, urinary retention, urethral injury, and erosion. Now coming to the literature, we have what is the main difference? So TVT is mostly offered in thin young patient with limited urethral hypermobility, and it avoids groin discomfort. Whereas TOT can be offered to patients with previous retropubic surgery, in patients with morbid obesity, with inexperience with TVT, and it has less post-op dysfunctions and complications. So what are the evidence supporting these? So we have this study comparing, published in Brazil Journal of Urology, comparing retropubic and transobturator approaches in the treatment of SUI. In this, 612 studies were identified, of which 16 were included, and it was seen that transobturator approach was associated with lower risk of bladder perforation, retropubic or vaginal hematoma formation, and long-term voiding dysfunction. But it also has high risk of thigh or groin pain. So they concluded that TVT and TOT has analogical objective and subjective cure rate, but transobturator approach was associated with lower risk of several complications. A similar study was published in Journal of Urology in 2019 in patients with high risk for recurrent SUI, and in this 28 studies were included. This study found that objective cure rate was more in retropubic group compared to transobturator tension-free vaginal tape, whereas there was no significant difference was found in overall complication between retropubic and transobturator group. Now, this study published in Curious in January 2023, transobturator versus retropubic in elderly women with SUI. So it concluded that more intraoperative complication, especially bladder injuries, were recorded in TVT group, whereas postoperative hematoma and tape loosening were significantly more frequent in the TOT group. AGOG also supports this. The cumulative in this study, serious complication and recurrences after retropubic versus trans-obturator group, the cumulative 2-year risk of serious complication was more in transvaginal tape group, that is retropubic group, 5.8%, and 2.9% in the trans-obturator group. But the cumulative 2-year risk of reoperation for recurrence of SUI was more in TOT group, that is 2.8%, and it was less in retropubic group. So they concluded that TOT is associated with lower risk for serious complication, but has a higher risk of surgical reoperation for recurrence. For if we see the individual study of for efficacy and follow-up for trans-obturator tape, so this study was published in JOGI in 2021 and included to 85 women and follow-up over 3 years. In this, it was shown that in TOT, groin pain was the most common complication, that is 28%, followed by urinary detention, that is 7%, and then mesh exposure risk was 3.5%. The complete cure rate at 6 months was 83%, and failure rate was 4%, whereas at 3 years, the cure rate was 79% and failure rate was 8%. Only 2 patients required reoperation and 12 patients were managed on conservative. So TOT is an effective and safe surgical treatment modality. Similarly, for retropubic tension-free vaginal tape, this is a long-term study. The median duration of follow-up was approximately 10 years. And in this, the objective cure rate was found to be 90%, and only 2.3% of the women required repeat SUI surgery. So they concluded that long-term objective and subjective outcome after retropubictivity is excellent with lower number of reoperations. At last, this is a study published in European Urology 2017 with updated systematic review and meta-analysis of all the surgeries like Birch-Colpo suspension, pubovaginal slings, and mid-urethral tape in the surgical treatment. So 28 RCTs were identified, and it concluded that patient receiving mid-urethral sling had significantly higher overall objective cure rate than those with Birch-Colpo suspension. Patients undergoing mid-urethral sling and pubovaginal sling had similar cure rates. Patients treated with retropubic TVT had higher subjective cure rate than those receiving trans-obturator TVT, but trans-obturator TVT had lower risk of intraoperative complications. Similar outcomes were noted for retropubic TVT and trans-obturator TVT with follow-up duration of more than 5 years. And there was no significant difference in efficacy were identified when comparing inside to out and outside to in trans-obturator TVT, but vaginal perforation was less common with the former. So strength of the studies was it included large cohort size. The limitations were it is a retrospective study, and use of diagnosis codes can be associated with coding errors. Unable to identify patients sought care for complication outside of their original healthcare system, and also if patients are treated with more conservative measures. Then the limiting the follow-up period to 12 months underestimate rates of recurrence and complications such as frozen. So my take-home message will be a thorough history and clinical examination to be done before surgical management of patients with SUI. Pelvic floor muscle therapy should be included in first-line conservative management program for women with stress and any type of urinary incontinence. Birch-Colpo suspension is the gold standard for SUI. Mid-urethral slings are replacing the other surgical modalities. Based on data available, TBT is superior than TOT on short run, but more invasive, technical, and has slight more intraoperative complication. On long-term, efficacy on TOT and TBT is similar. Thank you.
It was very well presented. Dr. JB, your comments, please.
Is Dr. Srikala Prasad here? Yeah.
Dr. Archana is
Archana,
there.
you want to comment?
Yes, sir. The presentation was very crisp and elaborate.
You are muted, please.
Am I audible?
No, we can hear her.
Yeah.
You're audible. Yeah.
Yeah. actually not very much into a urogenic person, but even what I could understand, of course, bulk corpus suspension is the main modality of treatment for SUI. And of course, we have been using more transobturated tape than TVT. But of course, as it was summarized in the presentation, the long-term complications are almost similar. Sir, I would like to know from you, GB Sharma sir, because you are the expert in this field. What is your experience on TVT and TOT?
Okay, yeah. Yeah, thank you, madam, for that. Thank you, Dr. Nisha, for your wonderful presentation. And I'm happy with Nisha that not only she covered that one particular topic of Journal Club, but she gave, review of, overall surgeries for SUI. So she did a good job. I think it will be useful for the postgraduates who are attending this ICOG, Journal Club. So basically, like in our practice, madam, we are fairly happy. We have been doing burst corpus suspension for more than 20 years now. And the results of burst corpus suspension are very high, between 80 to 90%. But only thing that's a major operation needs special training. And usually, we tend to combine. If I got a patient who is needing abdominal hysterectomy, okay, like large fibroid along with the SUI, so I tend to combine then burst corpus suspension with that. Similarly, people doing like they can do TLH and laparoscopic births also, that can be done. That is one option. Similarly, but the patients who are undergoing vaginal hysterectomy, like some patient goes prolapse with SUI, then I tend to combine that with the vaginal procedure, which usually is like initially we started TVT, but there is 6 to 8% bladder perforation rate in TVT. So after that, then we started doing TOT because the results, though some people say that TVT may be slightly superior to TOT, especially for patients, failed cases or intrinsic sphincter deficiency. But in my practice, I found both procedures are equally good. So it depends which procedure we are more experienced and more we feel at home. But 6 to 8% bladder injury rate is just not acceptable to me. So I immediately switched to TOT. I tend to do inside out, but both inside out, outside in, both are equally good. So it just depends what we have been trained in. So you can use inside out, outside in, results and efficacy of the two are equally good. But even then, ever since US FDA gave warning, and then has been an issue with the European Union and UK. Because they are also message, and the previous speaker did speak about mass erosions. So there have been issues in UK where these TVT, TOT are no longer available, and then they have forgotten how to do births. So now we are going back to pubovaginal sling surgery, in which we use patients' own tissues. So Mansi is sitting there. We did a thesis on more than 35 patients, in which we gave like to 20, I think 15 to 20 patients. We did rectus fascia sling surgery. So we use rectus fascia sling about 18 to 1.5 centimeter in size as a mid-urethral sling. But in that case, we had to do like laparotomy for these patients. It's a bigger operation. And the results were excellent, almost 95 to 100% efficacy. But the complication, more difficult operation takes longer, and complications were initially higher, like some patients of bladder retention, local hematoma. Gradually, after we did 5 cases, we started leaving a drain there, and we routinely started keeping catheter for at least initially 5 days, later 72 hours. So things got much better. Later on, we came with the this tensor fascia lata. So tensor fascia lata, we take the help of our plastic surgery colleague, but we can ourselves also do with a stripper. So again, we take 8 centimeter into 1 to 1.5 centimeter strip of fascia lata, which can easily be removed with a stripper with a tiny incision there. And in that case, we use the TOT sling, TOT, and with those needles we are using. We do put the TOT basically using the other previous needles and using the tensor fascia lata. So we have done about 8 cases, and we haven't yet the results. Initial results appear to be fine, but we are awaiting to complete our 15 to 20 cases, then we'll try to publish it. But we are finding good results. It's a minor operation, smaller operation. So those patients where there is like patient very obese, or patient has got previous abdominal surgeries, previous laparotomy, scarred, or this thing. So in those cases, it's a good idea to use this TOT using tensor fascia lata. And otherwise also, like, it's a smaller operation, easier operation. and as compared to rectus fascia sling, which is more like TVT or putting standard. So these are the results which we find. So I think gradually in time, if because there is a real risk that ultimately these tapes, TOT, TVT using polypropylene mesh may be banned even in India. There is a real chance of that. So we have already got alternative with us. We can still do birth. I mean, birth always will remain there. And especially the patient undergoing abdominal hysterectomy, then it makes a very good idea. But we have opened the abdomen anyway, or we are doing like TLS. So with that, we can do laparoscopic births, or if we are doing TH, we can do, TH with births. I mean, with the same incision, we can do. So that makes a sense. So similarly, with vaginal hysterectomy, we can do this, either TOT or if the tape is available, which is still available in India, we are still using that. Otherwise, later on, we can use the tensor fascia lata. So now, even if any tape is banned, so we still have alternative with us, like either Birch corpus suspension, rectus fascia sling, or tensor fascia lata. So I think all urogynecologists should devise a plan in advance, so that if the tape is no longer available, like I visited UK, and there they have forgotten how to do Birch, and the tapes are not available. They haven't yet learnt rectus fascia sling, and also they were offering to the patient was Kegel exercises, and which is not actually very effective for that. So I think I'd like to have Dr. Sirikala's opinion also. Thank you.
Yes, sir. So I agree with you, sir, JB sir. And again, I also feel that the transobturator tape is really good. We've been doing it for so many years. The outcome is also, it is not the 1 year follow-up alone. Even 15-year follow-up, we see it is giving good results. The advantage of this transobturator technique is less chances of bladder injury. Because in retropubic, there is a chance of bladder injury. And then when you don't have proper scopes, 30, 0, 70, you may miss an entry. Because we have seen people having entry into the bladder and then forming stones out of it. So TVT is a good surgery, but then we have to have a strict protocol and do a check cystoscopy correctly. I'm a great fan of pubovaginal sling using rectus fascia. We have reduced the incidence of avoiding dysfunction after we followed the rule of 40 mm. So we tie the knot 4 centimeter or 40 mm from the rectus sheath. After which we no longer see that kind of avoiding dysfunction. We have just started doing tensor fascial lata, not much of experience in that. Otherwise, certain simple things I see. Clinically, if you see that the urethra is immobile and the patient has got a significant leak, it is an intrinsic sphincter deficiency. Even without urodynamics, a small arithmetics. Again, history-wise, if the patient says small degree of stress and a marked leak, for example, she just tries to clear her throat and she leaks markedly, then it is ISD. If it is an ISD, this patient will require robust surgery, either in the form of a retropubic TVT or a pubovaginal sling. Otherwise, it's a simple stress urinary incontinence. There is some amount of urethral hypermobility, then we can go in for a transobturator technique. That is one rule which I follow. Second rule is I'm trying to do it from below. I'm doing a vaginal procedure, trial vaginal or anything. Then I combine with a synthetic sling. Again, here, if the patient, you feel, you're doing something else, urethroplasty or has a urethral diverticulum, even though you're doing it from below, you must not use a synthetic sling. It is there we need to have a autologous fascia. And if you're not opening the abdomen, harvesting the tensor fascial lata with the stripper will be very good. Again, I would reiterate a good history taking, clinical examination, investigations, and then choosing the right type of surgery. For example, if the post-void residue on ultrasound is very high, then you need to worry whether this patient has got a voiding dysfunction predominantly, has got an obstructive voiding, or has got a hypotonic bladder. In these patients, you must avoid putting a sling because you'll be worsening. So like that, there are many things which it's not just putting leaking, and choose the best sling for her. That would go a long way in helping her problem.
Thank you. Thank you,
I
madam.
think those are very useful words. I think Dr. Shrikala.
Yes, ma'am.
The experience really shows, Dr. Sharma, Dr. Shrikala,
Yeah,
Dira, I
thank
think
you,
Dr.
Shikala
Archana.
ma'am,
It's a
and
pleasure. Yeah,
thank you,
it's
Shikala ma'am
amazing.
and JB Sharma sir for sharing
Thank
your
you, ma'am.
vast experiences. And
So can you tell us about the rule of 4 again? You said
No,
tying the,
see,
yeah.
JB sir was talking of avoiding dysfunction in pubovaginal sling. I'm a great fan of that. And you know, if you have to put the catheter to the patient for a month or so, you will know how difficult it will be to answer to the patient. So we found an Australian study where they had analyzed and found that if you follow the 40 rule, that is, you're bringing the proline threads into the abdomen, bringing it out of the rectus sheath. After you close the rectus sheath, you will tie the proline threads, which you have brought from both sides. There, don't make the knot lie flat on the rectus sheath. You can either keep 2 fingers or you want 4 centimeter here. So, meaning it is not tight. You don't want obstructive voiding. That is
Just
the
like
only
we
rule.
leave an
So,
artery forceps, no, under
yeah.
in the like suburethral area, same way in the abdominal we leave an artery forceps, but so that will make, because it is usually we make it tight, actually too tight, and then fibrosis also occurs. So patient avoiding dysfunction. So by keeping it loose, by 40 rule, what madam means is that 4 centimeter gap has to be there. That means not is lying loose there. But below submucosally, like vaginal, suburethally,
It gives a
it is
hammock.
okay. It's not so loose also that patient will have SUI. If you keep it too loose, then patient can continue to have SUI. So we make it such a way, because suburethral it is okay, but above we will lose 40 rule. That's what man means.
In
So
fact,
then the voiding
when
distance will not be there. Yeah.
one difference between using a synthetic sling and using an autologous fascia is, when we use a synthetic sling, we don't anchor the sling to the periurethral tissues, because the macropores, we say that 75 micron size, those macropores will allow ingrowth of fibroblasts and macrophages and will convert it into a sling. And it has got a kind of a Velcro effect. It will stick there. So, but we don't want there also to be tight. So we put a Metzenbaum scissor and then tighten it and cut. Here, what we do is, you put it like a hammer. You anchor the rectus fascia sling to the periurethral tissues. Either in a midline, one bite you can take, or I prefer, supposing the sling is like this, 1, 2 down, like right upper, right lower, left lower. On all 4 corners, I'll take a bite on the periurethral tissues so that it stays there. It doesn't run. And then later you have the fibrosis and everything. And when you bring it along the retropubic area with further in the course of the postoperative period, you have very good continence. And believe me, if you have evaluated the patient well and there is no neurogenic bladder, this pubovaginal sling will never let you down. It's a panacea. Like, I mean, you can use it for all kind of incontinence. You can put in a pubovaginal, provided it is not a neurogenic bladder.
Yes.
Very useful. I think that
Very
that
useful,
was
very
extremely, yeah. Your comments and your experience really shows, madam. So, Dira, anything? Your experiences, please. We are looking forward to a young voice.
I am deeply humbled actually to be a part of this panel, because it has Dr. JB Sharma sir, Dr. Shrikala Prasad ma'am, Dr. Archana Kumari. I really look up to them, and they inspire me, and I have much to learn from them, and I think from this journal club I even take back more than what I give. So I'm really glad to be a part of this. If I'm just like posing a question, ma'am. I had a patient in which ma'am and sir both. I had a patient in which I inserted a TOT. One of them, one patient had right-sided groin pain. I did give her like pre-gabalin, new GABA-M. I gave her, I sent her to a physiotherapist, but her pain reduced, but it was still 4 out of 10. Earlier it was 8 out of 10. Is there anything more that you would recommend, or that we can help these patients?
Your voice was not heard properly. Can you repeat again?
Right. Ma'am, I had a patient in whom I inserted a transobturated tape. She had complaints of a right-sided groin pain, which she came back after a month with. I gave her pre-gabalin, new GABA-M. Sent her to a physiotherapist. So initially her pain scale was around 8 out of 10. it's around 4 out of 10, but she does continue to have a little bit of dragging pain. Is there anything that you would suggest or that you would do for a patient ahead like this?
There is no exposure anywhere, no? The
No,
mesh
no,
is
ma'am.
not.
No,
No erosion, no exposure,
no.
but only pain. But the
Only-
pain has come down.
Yes, yes, ma'am. It's come from 8 on 10
8
to 4 on
4.
10. Yes.
Maybe I would give some more time before
Okay.
I venture anything, because if there is an exposure, then I would go forward. Or if there is an infection, if I feel there is an infection and an exposure, I'll definitely think of surgical. Otherwise, I'll give some more time.
Okay. Okay, ma'am.
Yeah.
Thank you.
I mean, if the
They-
pain remains 8 out of like 8 by 10 or 10 by 10, or there is mass erosion or excruciating pain, patient is in absolute agony. So I attended ICS conference in Canada. I think Mansu was also there. So where this person presented, so then they tried to remove the tape actually. And in this case, it is not the a tape from the vagina. You have to remove the tape from the obturator foramen and all. And that area actually is we are not used to work in that area. There can be vessel injury, and they showed in Canada actually in Toronto conference that how they got to the adductor magnus, adductor longus tendon, and they removed that. So it's a very difficult surgery, and all you need to take the help of those. So that is a rare thing. But as madam said, I think you wait for her, give her more anti-inflammatory and all. So usually it should settle down. But very, very rarely, I mean, till now we have never needed to do any removal of such surgery. Only 2-3 mass erosion we had partial, they were in the vagina. So we just removed as much as possible. And in one case, it reappeared a little bit more. So we, removed as much as possible and covered the vaginal mucosa over that. But if you really have to remove the, if the patient is in agony or infection, as madam said, that they showed in Canada, so it was infection. So they did like, dissection in the groin and all. And even I was not able to understand because we don't work in that area. So you need to take the help of, general surgeons, especially who work in those areas. And it was very difficult surgery. Patient, I mean, lot of like adductor tendon was, lot of fibrosis was there in that area. And ultimately, but they were able to remove all part of the mess in that area. So that is the ultimate thing you have to do if it is a like, it cause infection in that area and excruciating pain.
Thank you, sir.
But I'm happy, Dr. Dhira, you are doing a good
So
job.
thank you very much. I think it's been
Yeah.
I think it's been a very informative meeting and very interactive too. We learned a lot actually through people's varied experiences.
Thank you.
So, any questions from the audience? We would be happy to take any questions. So, Muntaha wishes to know for ISD which surgery is better. I think Dr. Shrikala was mentioning ISD, so Muntaha
ISD.
would like to know. Yeah.
For ISD, it is better to do TVT actually. If patient has got intrinsic sphincter deficiency, that is a condition. Yeah. So
TVT
in this
or
either pubovaginal sling. So in that
or-
case, either TVT or pubovaginal sling
Yes.
should be done for that case. Otherwise, TOT and TVT, they are equally good for other cases. But intrinsic sphincter deficiency, pubovaginal sling or TVT are superior.
So what about Birch? Abdominal
Birch corpus
surgery?
suspension is very good, but only thing that it's a bigger operation, and we are trained in that, but all patients are not able to do it. Somehow the training is lacking. It's not trained in the routine PG curriculum. So only the urogynecologists are aware of it, and slightly I tend to do it, but that's what I was telling, that if you are doing abdominal hysterectomy, then it makes sense to add Birch corpus suspension to that. Those patients with fibroid uterus with SUI, I always combine Birch with abdominal hysterectomy. Similarly, you can do TLH and laparoscopic Birch also. But generally, if it is a pure SUI, so not many people will go for Birch because it's a laparotomy, large, bigger operation. Catheter has to be kept for minimum 72 hours. Some people even keep up to 5 days. So, and those results are very good. So you can do it. But I mean, considering that if you have got minimal invasive procedure like the TOT, TVT and all, then probably like, now they have an edge over Birch. But definitely, I mean, it is a good operation. It will never go out of vogue. And if you are combining abdominal hysterectomy or laparoscopic hysterectomy, then Birch is a good option.
I agree totally with that. We actually also do the same. So anything which requires an abdominal entry, Birch, it makes sense to use that procedure.
So till we get
So
any
I
more
think-
questions, so I take this opportunity to thank Dr. Radhika for beautifully orienting it, and Dr. Sir, our ICOG chairperson, ICOG secretary, all of them, they were there, and we thank them also for this opportunity.
So many thanks from our side, and especially to Nisha for moderating that for the time when we could not be present. So, and it's been a very interactive, highly informative session. I think presentations were absolutely
We
brilliant.
learned too much today
Thank you.
from the experience of JV
And
Center.
Radhika,
thank
if
you.
Nisha can be sent a certificate also that she presented it for her future career, I think.
I think Dr. ICOG people, they'll certainly tell the ICOG to
It will
consider
be
doing
useful
that.
for her, certificate for her future.
Yeah, sure.
So
So
thank
I
you
think
very
we can
much.
call it today. Thank you very
Yeah,
much.
yeah,
Thank you.
everyone.
Yeah.
Hope we will
Thank you
meet
so
you
much.
very soon.
Thank
Yeah,
you.
okay. Thank you.
Thank
And I
you.
think Dr. Sirikala, you need to train our fellows also sometime.
Yes, sir. Yes, sir. It's a pleasure.
Yeah. So
It's
if
a
you
pleasure.
allow, we'll send them for a few days to you, man, Dr. Sirikala. They are all of
Yes,
them
sir.
are fans of you.
Thank you.
Thank you.
Thank you. Thank you.
Okay then. Good evening all. Have a good evening.
So
ahead.
proud,
you.
Dhira, you are sitting with us now. From
Nah.
that side of the table, I examined Dhira. Do you know in her?
Yes,
thing?
sir was
And
my
how-
examiner.
No, I'm so delighted for you. Thank you.
I'm deeply humbled, sir. Much to learn from all of you. Thank you. Thank you, sir. Thank you, ma'am. Thank you.
Thank you.
Thank
Bye.
you.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Bye bye.
you so
Bye.
Thank you,
See
Dr.
all.
Parul sir is there, Dr. Sarita ma'am, Dr.
I think they
Sheila
have all
madam.
left.
So I must thank all the
So-
ICOG person and you and Charmila madam, the convener, for making part of this important journal club and
So it was
research.
certainly a pleasure and privilege to have you all here. Thank you very much.
Thank you.
Thank
ma'am.
you, Radhika, ma'am.
Bye. Bye.
Thank you,
Thank you
Dheera.
so much. So from here, I'm ending this meeting.
Yeah, sure. Thank you.